this chapter, we'll be discussing about open fractures and certain important miscellaneous concepts that you have to know for your exam. So we'll be covering open fractures, external fixation, amputations, prosthesis, crush syndrome and cast syndrome in this chapter. Okay, so we'll start with open fractures. What is an open fracture? Open fracture is a fracture associated with a wound, isn't it? But is it any wound? No, a wound should be deep enough that the fracture hematoma should communicate with the outside environment. That is the definition. Okay, so fracture associated a wound through which the fracture hematoma communicates with the outside environment. This is what we call as a open fracture. So what is the problem here? All the dirt, the debris, the infection, germs, everything is going to enter into the fracture site and it's going to cause complication. And which is the primary complication we are scared of? Infection of bone, isn't it? This can cause infection of bone and this can result in chronic osteomyelitis, or it can cause non-union and lots of problems. So the problems can be high chance of infection. Infection can occur in the wound, it can occur in the bone, and if you put an implant in that site, that is it. The implant is also going to get infected, isn't it? You can't even imagine putting a implant or a plate or something in this area, isn't it? This is going to get infected. Then there is going to be a high chance of non-union. Why? First of all, there is loss of the fracture hematoma, isn't it? We know that the first step in fracture healing is what? Formation of the fracture hematoma. Fracture hematoma is formed, but that is immediately lost to the outside, isn't it? Because it is open to the outside environment. And second, there is usually a lot of soft tissue stripping. All the soft tissue attachments which bring in blood supply from the outside is lost in open fractures. Again, this will compromise healing. And finally, it is very difficult to treat these patients with plasters. We cannot put an internal fixation device because the plate or nail will get infected. We cannot also put plasters because if you put a plaster, the wound is going to get infected, it is going to get festered and it's going to be really bad. We cannot do even that. So what do we usually do? Yes, we usually do something called as external fixation, isn't it? We learn about that in a little bit. Now, before we manage any of the open fracture, we have to classify the fracture based on a very important classification system called Gustilo-Anderson classification. Gustilo-Anderson classification. There are 3 grades according to this classification, and it is mainly based on the size of the wound. And secondly, it is based on the severity of fracture. These are the 2 things taken into account. Grade 1 is wound less than 1 centimeter, a tiny wound. Grade 2 is where the wound is between 1 and 10 centimeter. Grade 3 is wound more than 10 centimeter. This is easy, but there is a catch here. There are certain features that we call as grade 3 features, such as a fracture because of a high energy trauma, an extensive soft tissue damage, segmental or comminuted fracture, gross contamination or vascular injury. If any of these 5 things are there, then it automatically becomes a grade 3 fracture irrespective of the size of the wound. Size of the wound is the most important grading factor, but that is not the only factor you have to take into account. Always keep that in mind. Okay, any of these grade 3 features are there, then you don't have to look at the size of the wound at all. I'll give you an example here. So this is a type 1 fracture, isn't it? There is a very tiny dot, a wound less than 1 centimeter on the skin. So this is a type 1 fracture. Type 2 fracture, you can see there is a small wound around 5 centimeters in the tibia, on the tibia, and you can see there is a tibial fracture. This is a type 2 open fracture. This is a classical type 3 fracture where the wound is more than 10 centimeters. Now let's look at this case. See, there is a wound here which is around 6 centimeters in size. Now based on this wound size, and there is a fracture of the humerus, so this should be a type 2 fracture, isn't it? But can you call this a type 2 fracture? Look at the type of fracture. The humerus is completely shattered, isn't it? It is a grossly comminuted fracture of the lower part of humerus. So if there is gross comminution like this, what do you call this fracture? This fracture will automatically become a type 3 injury, isn't it? So this is a type 3 fracture. Look at another case. So this poor lady has fallen into a sewer and there is a fracture of the tibia. And there is a 1 centimeter wound. So because the wound is 1 centimeter, you might think that, oh, this is only grade 1. But is that correct? Look at the gross amount of contamination. The injury has occurred inside a sewer. So you can imagine the amount of contamination that would have occurred. So can you call this type 1? No, it is much more severe, isn't it? So this is classically type 3. So this is why I told you, irrespective of the size of the wound, look at the other factors as well before you decide on the type of injury. Now, the grade 3 fractures are further classified into 3 types, A, B and C. Type 3A is a simple wound more than 10 cm. Type 3B is where there is extensive soft tissue loss requiring skin grafting or flap cover. Type 3C is vascular injury requiring repair. So let me tell you. So in type 1A, there is a simple wound which is 11 or 12 centimeter. What you can do is that just put sutures like this. You can just put sutures like this and you can close the wound. That is it. Now, in type 3B, a large part of the skin or soft tissue is missing. The bone is completely exposed. There is nothing to put suture there. So what will you do? You will have to call a plastic surgeon. A plastic surgeon has to come and he will take a skin graft or a flap from somewhere else and place it over the wound and cover it. So you need a soft tissue procedure to cover the wound. So this is what we call as a type 3B. Type 3C is where a major blood vessel is injured. Major artery is cut. And what will happen if a major artery is cut? The limb is going to go in for gangrene, isn't it? So you have to save the limb. So you'll have to call a vascular surgeon. And the vascular surgeon is to come and repair the vessel. So this is how you classify type 3 fractures, A, B and C. Now how do you manage open fractures? So remember, whenever you see open fractures, don't jump and treat the fracture first. Treat the wound first. Wound care comes first, then comes fracture care. Okay. So always keep that in mind. Okay. So how do you do wound care? First and foremost, when the patient comes to you, remove all the foreign debris. Many of these patients will have leaves and muds and stones and things like that at the fracture site. So you clean the area, you remove all these debris. Then the next step is to use plenty of normal saline to wash the wound. You use maximum amount of normal saline to wash the wound. They said that in type 1 fracture, you need at least 3 liters of water to clean it. In type 2, you have to use at least 6 liters of normal saline for cleaning the wound. And in type 3, we need to use at least 9 liters of normal saline to clean the wound. So this is the least amount of normal saline that you are using. You can use more than this, that is okay. But at least this much amount of normal saline must be used to clean a particular type of open fracture. Then you can use betadine and hydrogen peroxide as analogs to clean the area. Once your wash is done, you go in for debridement. What is debridement? Removal of dead tissues or contaminated tissue is what we call as debridement. So you completely remove all the dead and unclean tissues with a knife and you clean the area completely. Then you can also remove all the contaminants. Then you start the patient on broad spectrum antibiotics. So this is the first step in taking care of an open fracture. You manage the wound first. Once you have finished managing the wound, you go ahead and start managing the fracture. So how do you manage a fracture? It depends upon the type of injury. So if it is grade 1 fracture, you can go in for internal fixation. You can do plate fixation or nailing, it is okay. In grade 2 and grade 3A fracture, these are treated similarly. If the fracture is uncontaminated and the patient has come to you within 6 hours of time, you can do an internal fixation. If the wound is contaminated and the patient has come to you after 6 hours period, then you have to do an external fixation. Type 3B, there is only one option. You have to do external fixation, but there is a large soft tissue loss. So you'll have to call the plastic surgeon and do a plastic procedure. Either a skin graft or flap cover has to be done. In grade 3C, you do an external fixation, and because there is a major vessel injury, you do a vascular repair as well. So this is how you manage the fracture. Now we learnt about external fixation. What is this external fixation? It is the treatment of choice for open fractures, isn't it? It is a device by which we put pins or implants on the outside of the body to stabilize the fracture inside. So that is the concept of external fixation. But what is the mechanism here? I will draw a picture and show you. So imagine you have a fracture like this. Okay, you have a fracture like this. This is an open fracture, unfortunately. Open fracture means there are a lot of debris and dirt and everything has entered the fracture set. You have cleaned everything well, but even then bacteria will be definitely there, isn't it? So let's imagine that this is the zone of contamination. Now imagine you are very brave and you try and fix the fracture using a plate here. What is going to happen? Your plate is in the zone of contamination. There are millions of bacteria there. What is going to happen? Your implant is going to get infected, isn't it? And within few weeks you will have to take the implant out to control the infection. So that is the danger here. So you cannot put an internal fixation device through the zone of contamination. So what we do is that we keep away from the zone of contamination and we put 3 pins proximally and 3 pins distally. And you fix the pins using a rod like this. You stabilize using a rod. This is what we call as external fixation. You can see that we have clearly avoided the zone of contamination. There are no implants in the zone of contamination and we are far away from there, and we have also successfully stabilized the fracture. Okay, so this again you can see here there are 2 pins distally and 3 pins proximally, and they have been connected using rods. There is a special type of external fixation device that you see in this picture. This is a Ilizarov ring fixator, where you use the rings and other kinds of wires to fix the bone. It is an external fixation device. Here we are using pins and rods. Here we are using rings instead. This is called Ilizarov fixation. This is a image-based question for you. This is a previous year topic, Ilizarov ring fixator, and usually the question asked revolves around the uses of Ilizarov fixator. So this is something you need to know. Generally, I told you external fixators are used for what? It is used for treating open fractures. But Ilizarov fracture fixation is not like that. It is very versatile device. You can use it for multiple purposes. Okay. For example, it can be used for fixing open fractures. Even if the fracture is not open, for complex closed fractures also you can use it for fixation. Then for infected non-unions, it is the treatment of choice. For gap non-unions, that is, you can see there is a non-union here and you can see a large gap, and with Ilizarov fixation you can see that the gap is completely closed. So you can use it for gap non-unions, deformity corrections and limb lengthening procedures. So these are the uses of Ilizarov fixator. Okay. Now sometimes a patient comes to you like this. You can see how bad the injury is, isn't it? Can you put an external fixation here? Can you do a flap cover? No, it is nearly impossible to save the limb of the patient, isn't it? When the injury is like this, you will have to do amputation. You will have to do amputation to save the patient's life. Now there is a scoring system that we use to decide whether to do an amputation or not, which is called the MES score. MES score, or Mangle Extremity Severity Score. MES score. It has 4 things in its calculation. One, there is something called as mechanism score. Then you have ischemia score, shock score and age score. Mechanism score, if it is a low energy trauma, it is 1 point, medium energy 2, high energy is 3 and very high energy is 4. Ischemia score, if the pulse is reduced but perfusion, that is capillary filling, is normal, you give it 1 point. If the limb is pulseless with reduced capillary refill, it is 2. If the limb is completely cold, paralyzed and insensate, that is complete loss of vascularity, it is 3. Then you have shock score. If the BP is more than 90, it is 0. Transient hypotension is 1 and persistent hypotension is 2. Age score, a patient less than 30 is 0, 30 to 50 is 1 and more than 50 is 2. You take the total score, and if the score is less than 7, then the patient is not that bad. You can do an external fixation and try to save the limb. If it is more than 7, you have to do an amputation. More than 7, amputation. Okay. Let's now discuss a few important concepts regarding amputations. Whenever we are learning about amputations, there are 2 things that very similar terms that come to mind. One is amputation and other is disarticulation. What is the difference here? Amputation is surgical removal of a part through one or more bones. Disarticulation is surgical removal of a part of a limb through a joint. So imagine this is the knee joint here which I am drawing. This is the femur, this is the tibia, and you have the fibula somewhere here. If you are doing an amputation, You do the amputation through multiple, one or more bones like this. You cut at this level and you remove the distal part of the limb like this. This is amputation. Okay. Now what is disarticulation? In disarticulation, you are not doing anything to the bones. You are just cutting the ligaments. You cut the ligaments here. And obviously other soft tissues and blood vessels, everything has to be cut, but primarily we are not cutting the bone, we are cutting the ligaments, and you completely remove the part. So this is what we call as disarticulation. Okay, so this is the difference between amputation and disarticulation. Okay, what are the indications of amputations or disarticulations? Most common indication worldwide is peripheral vascular disease. Peripheral vascular disease because of ischemia. This is the most common cause. Second, in India, the most common cause is traumatic, either because of a crush injury or unsalvageable damage because of an RT or something like that. This is the most common cause in India. In Western countries and in whole of the world, it is POVD. Okay. Then gas gangrene is an indication, malignant tumors, frostbite, congenital anomalies, and flail limb with trophic ulcers. So these are all indications of amputation. There are different kinds of amputations based on the site of amputation. So if you are amputating the entire shoulder girdle like this, you call it 4/4 amputation. 4/4 amputation. Amputation through the humerus is above elbow amputation. Amputation through the elbow is elbow disarticulation. Through the forearm is below elbow amputation. Then you can have wrist disarticulation. Through the carpal bones, we call it transcarpal amputation. Through the metacarpals, it is transmetacarpal amputation. What about the lower limb? When you are amputating the entire hip girdle, you call it hindquarter amputation. Then you can disarticulate the limb through the hip disarticulation. Then if you are amputating through the level of the femur, you call it above knee amputation. Then comes knee disarticulation. Even below it, you can amputate through the leg. You call it below knee amputation. And then even distal to it, you can have ankle disarticulation. Now, whenever you are doing an amputation of a limb, always try and keep an optimum length of amputation stump. Why is that important? Because if the amputation stump is too long or too short, it will be very difficult for us to design and fit a prosthesis to the limb. So always keep in mind to keep an adequate length of the stump. So in the case of below knee, we usually require around 6 inches stump. Above elbow it is 7 inches, below elbow it is 8 inches, and above knee it is 9 inches. You can remember it like 6, 7, 8 and 9. But this is an old concept. Nowadays the concept is different. Nowadays we believe that whatever the length of the prosthesis, we can actually make prosthesis without any problems because of the advancements in technology. So nowadays the concept is keep the maximum length of stump that is available for you. That is the ideal thing. Okay. Now let's look at the types of amputation based on the closure of wound. Now there are two kinds. One is your open amputation, other is your closed amputation. What is open amputation? It is also called as guillotine amputation, where you are cutting the limb at a particular area and you are not creating any flap. So you are leaving the wound open and you are allowing it to heal by secondary indentation, or you are planning to do a skin grafting to cover it later. So this is what we call as an open amputation or a guillotine amputation. Okay, so the cut end of the stump is left open to heal by secondary indentation. So this is used in severe infections where if you close the stump, there is a risk that pus can accumulate inside and there could be reinfection. So in that condition, we keep the limb open. Then in severe contamination, again there is a risk of infection if you close the wound. Again, we leave it open at that stage. Then need for quick surgery. There are certain conditions where the disease will be progressing very fast, and if you don't amputate the limb as early as possible or as quickly as possible, it can threaten the life of the patient. Can you give me an example of that condition? It is gas gangrene. Gas gangrene. Gas gangrene is rapidly spreading and you have to amputate the limb as early as possible to save the life of the patient. Okay. Now what is the disadvantage? The disadvantage is that you have to do a secondary procedure to close the wound. Again, you have to close it somehow, isn't it? Either you allow it to heal by secondary indentation, but it will take months for that, or what you do is that you do a skin grafting on top of it. Okay. Now what is closed amputation? It is the most common kind of amputation where which we do, where what we do is that we create flaps, anterior and posterior flaps, and we suture the flaps together to close the cut end of the wound. So whenever we are creating flaps, three kinds of flaps can be done: symmetrical flap, skewed flap, and a long posterior flap. What is a symmetrical flap? Here the anterior flap and the posterior flap both are of equal length. So what will happen? You get a beautiful stump like this where the scar is in the center. This looks very nice, but there is a problem. What happens when you put the prosthesis? Weight bearing will be on the scar. So is it good or bad? This is not good, isn't it? So it is not used nowadays unless it is essentially required. If there is no other go, we do this, otherwise we do not do this. What we generally do is a skewed flap. What is a skewed flap? Here the posterior flap is slightly longer than the anterior flap, and you can see the scar will come anteriorly like this, and this is the most common type of flap that we use. So what is the advantage here? You can see a nice, beautiful, soft weight bearing area here. So whenever we are putting a prosthesis, the patient would be very comfortable to walk on it. Now what is this long posterior flap? Here the posterior flap is much longer than the anterior flap. So what is the advantage here? It is usually used in ischemic conditions. Ischemic conditions, okay, such as POVD, where the posterior compartment will have much more blood supply than the anterior compartment. So you can use this method. Now what are the steps of amputation? First thing that we orthopedicians generally do is to apply a tourniquet. This is usually effective in traumatic amputations. But remember, tourniquet application is completely contraindicated in one condition. Can you tell me which condition? It is contraindicated in POVD. If the patient is suffering from a ischemic condition and you are doing an amputation for it, tourniquet must not be applied. Why? Already the blood supply is low and you are applying a tourniquet, and now you are diminishing the blood supply to the normal areas also. So don't apply tourniquet in an ischemic condition. Traumatic condition you can apply it because this is going to reduce the bleeding. Then you do the skin incision. Usually for BK amputation we use a skin incision called the fish mouth incision. Next step is to divide the muscles. Whenever you are dividing the muscles, we divide the muscles slightly longer. So the muscle cut is longer than the bone cut. Why? Otherwise you will not be able to cover the ends of the bone and suture the muscles together. So you need the muscles to be a little longer. Then you divide the vessels. So you divide the muscles at the level of the bone cut. And also use double ligages. Why double ligages? In order to prevent the slippages of the ligages, and if the ligages slip, it is going to cause severe bleeding, isn't it? So we don't want that to happen, so put double ligages. Then you divide the nerves. Division of the nerve should be proximal to the level of bone cut. This is very, very important, okay? So remember, nerve should be divided proximal to the nerve, to the level of the bone cut. What you do is that you pull the nerve maximally down and cut it at the higher level, so that when the nerves retract, it will go up. Otherwise, what will happen? It is going to produce a painful neuroma at the weight bearing area of stump. So remember, our stump should be ideal for putting a prosthesis and weight bearing, isn't it? So whenever you divide it very distally, what will happen is that it will form a painful neuroma there, and when you are putting a prosthesis and when the patient starts walking, there will be compression of this neuroma and there will be severe pain. So we always cut it proximal to the level of the bone cut. Then you divide the bone. After dividing the bone, prepare the bone ends. After cutting the bone, you will see that the edges of the bone is very rough and sharp. Then you use something called as a rasp. You rasp the edges of the bone to make it smooth. Otherwise, it is going to pierce the surrounding tissues and cause pain to the patient. Then you do the muscle closure. So there are two ways in which you can do muscle closure. One is myodesis and myoplasty. What is the difference? Myodesis is suturing muscle to bone. I will show you how it is done. Myoplasty is suturing one group of muscle to the opposing group of muscle. So I will show you. So this is myodesis. This is above knee amputation. In myodesis, you can see that amputation has been done at this level and the muscle has been taken round like this and drill holes are made in the bone and the muscle is sutured onto the bone. So this is myodesis, and this is the best method for fixing the bone, but it is contraindicated in POVD and sometimes also in infections. Ischemic conditions and infections, we generally do not do myodesis. We do myoplasty, where we have taken the bone cut here, and this is the anterior group of muscles, this is the posterior group of muscles. We take these muscle group together and we are suturing them together. This is what is called as myoplasty. Okay. So myodesis is good, but myodesis is generally not done in the setting of an ischemic condition or an infection. In all other conditions, you can do myodesis. Otherwise, you do a myoplasty. And once you do that, you close the skin and prepare the limb for prosthesis application. One of the most important prosthesis that is important for your exam is this above knee prosthesis. You don't have to learn much, just know the parts of the process, that is all. So, if you see this wide conical area you see here is called the socket or the quad socket or the ischial compartment. It is nothing, it is just a socket for fitting the stump, that is all. Okay, then you have a belt like this which is called the Silesian suspension. That can be asked as an MCQ. Silesian suspension is used to tie the belt around the waist. This is to prevent the prosthesis from sagging down. Then you have a knee unit, then you have the prosthetic shank or the shin of the prosthesis, and you have foot assembly. And if you look at the foot assembly, two kinds of foot assembly can be used. One is called a SACH foot and other is your Jaipur foot. So what is the difference between SACH foot and Jaipur foot? SACH is solid ankle cushion heel. So solid ankle cushion heel, this is one of the most widely used foot assembly throughout the world. But in India, mostly we use the Jaipur foot, which was developed by Dr. P.K. Sethi in Jaipur. So what is the primary difference between the SACH foot and the Jaipur foot? The primary difference is between the construction of the ankle part. If you see, the ankle part in SACH is primarily made up of metal. So it is very rigid. While in the case of a Jaipur foot, the ankle part is primarily made of wood and also rubber. So this makes it more flexible. That is the primary difference. So what is the practical differences? SACH foot has a rigid long keel. So it is a rigid foot. So a patient cannot squat with this. Patient cannot walk on uneven surfaces because the foot will not be flexible on it. It has a very unrealistic wooden-like appearance, so the patient has to wear a shoe. If the patient is not wearing the shoe, it can become wet and can get destroyed, and it is also costly. In the case of Jaipur foot, it is made up of softer short keel, therefore it is more flexible, so squatting is possible. The patient also will be able to walk on uneven surfaces. It is more lifelike, it is more similar to our Indian complexion. You can see veins and all are also visible on it. So this is more lifelike and the patient can walk without any shoes. It can be used barefoot and it is also much cheaper. But what is the advantage of SACH foot? SACH foot is usually more durable. Because it is made up of solid metal, it is much more durable than your flexible Jaipur foot. Okay. Now, rarely in certain unfortunate situations, we may have to do amputations in a child. I remember when I was doing my PG, we had to do an amputation, above elbow amputation for a child with a neglected supracondylar fracture with gangrene. So that is one of the painful experiences for me. So amputations in children are not pleasant at all. And there are certain points that you have to remember while doing amputation in a child. First and foremost, preserve the maximum length of the stump as possible. Second, always preserve the growth plate. What will happen if you damage the growth plate? There will be too much shortening when the child grows up. Then preserve the knee joint. If you are able to do a below knee amputation, do a below knee amputation rather than an above knee amputation. Prefer disarticulation more than amputation. Why is that? Because if you do an amputation, there is a high risk of something called as terminal bone overgrowth. What is that? See here, this child had an amputation at this level, but can see the bone has overgrown into sharp spikes like this. This is new growth. And over a period of time, it will pierce the stump and come out. And this is going to cause severe pain. So always tell the parents that whenever we are doing an amputation in a child, that revision surgeries may be required, because for example, this child will have to be taken for surgery again, and we have to excise this much part again to remove the overgrown parts. So this is one of the problems in amputation in a child. And finally, when you do an amputation in the child, as early as possible, start the child on a prosthesis, because it is magical to see how a child immediately acclimatizes to a prosthesis. So earlier you start a process, the child will be more acclimatized to it. Okay. Now let's talk a little bit about reimplantation, also known as a replantation. What is that? Replantation is a process of reattaching an amputated body part. Ideally, if there is an amputation to your body part, you have to fix it back within a period of 6 hours. Then the success rate is very high. You can maximum do up to about 12 hours of delay. But after 12 hours of delay, the tissue is already dead and there is no point in reimplantation. Okay. So imagine a condition where you are working in a small hospital and a patient comes to you with a amputated limb or an amputated finger or something like that. Now you have to send the patient to a higher center for reimplantation. How will you send the amputated part? See, there is a series of steps that you have to take. First, you thoroughly wash the cut part, finger or amputated limb, with water and normal saline. You remove all the debris, everything from it. Then you wrap the whole limb in moist gauze. Then what you do is that you put the whole thing inside a plastic cover like this. Then you put this plastic cover in another plastic cover which is full of ice. Otherwise, what you can do is that you can put this plastic bag inside an ice box. So these are the options. So remember, clean with saline, wrap in a wet gauze, place it in a plastic bag, place it inside a ice box or a bag filled with ice. Then you ask the patient to transport it to a nearby hospital. When the patient reaches the hospital, he will be taken over usually by a plastic surgeon, and he will repair the structures one by one. Now there is an order or sequence in which the structures are repaired. Do you know the order? See, generally the students usually think that it is the artery that is repaired first, but no, it is not like that. Remember, it is a bone that is fixed first. Then you repair the extensor tendon and the flexor tendon. Then you repair the artery, nerve, vein and skin. So this is the order. You start with the bone, then extensor and flexor tendon, artery, nerve, vein and skin. So this is the order of repair. Got it? Now let's discuss a very interesting but dangerous complication called crush syndrome. What is crush syndrome? It is a reperfusion renal injury which occurs when products of ischemia produced by prolonged crushing of tissues enters the systemic circulation. So it is primarily a renal problem and it occurs because of crushing of tissues. So which are the conditions in which you could get crush syndrome? For example, an RTA, there is a collapse or a RTA where the patient's arm or leg gets trapped under the vehicle, or there is building collapse and the patient gets trapped under the building materials. Then in earthquakes and battlefield injuries, these are the conditions where you can get crush syndrome. So what is the mechanism here? Please listen to me carefully. See, you might have all heard about the famous incident where a mountaineer got stuck in the mountains. He was climbing alone and he got stuck there because his arm got caught inside a boulder like this. The boulder fell on him and it completely crushed his hand. And he was there for I think 2-3 days and finally he escaped by cutting off his own arm. He amputated his own arm with a Swiss Army knife and escaped. So because he did an amputation there, he survived. Imagine if he had called his friends, what would have they done? They would have come there and removed the boulder. If they had removed the boulder, the patient would have died. Why? Because of crush syndrome. Now, why is this happening? The thing is that whenever there is prolonged crush injury, for example, he has been like this for, let's say, 2-3 days. So there is crushing of the tissues there. The tissue would have been dead by around 12 hours or 18 hours. The tissue would be completely dead. Now what is the next process? There will be ischemia of skeletal muscles and rhabdomyolysis. The skeletal muscles will get broken down, and there will be accumulation of myoglobin, phosphorus and potassium and all other toxic metabolites in the crushed arm. They will be there. But remember, these toxic metabolites are not yet entering the systemic circulation. Why? Because there is this blockade there. The crushing stone is actually preventing the toxic metabolites from entering into the systemic circulation. Now imagine his friends coming and lifting up the boulder. What will happen? Immediately all these accumulated toxins will enter into the systemic circulation. This is what we call as reperfusion injury. These ischemic products will enter into the bloodstream and cause an acute tubular necrosis. And the patient will present to you with shock, rhabdomyolysis and acute renal failure. So this is the problem of crush syndrome. So when you do an investigation of the blood parameters, you will see that there will be increased myoglobin levels in the blood, increased potassium, increased creatine kinase, increased phosphorus, metabolic acidosis will be there. Everything will be increased. Only one thing will be reduced. What is that? This calcium. This was a previous year question. The thing that is reduced in crush syndrome is calcium. Everything else will be elevated. And urine will also show myoglobinuria. Okay. So this is a very, very important table as well. Now, how do you manage crush syndrome? Remember, crush syndrome is primarily a nephro problem. It is treated by a nephrologist and not by a orthopedic surgeon. So basic concept here is to maintain a high urine output. How can you achieve this? The kidney is going to shut down, isn't it? You can do it by giving IV fluids, can give mannitol alkaline diuresis, and if the kidneys are already malfunctioning, you can start dialysis. And calcium gluconate is given for what? For hypocalcemia. And sodium bicarbonate is given for what? For alkalinizing urine. Okay, so these are the steps you can take. This is your crush syndrome. Remember, crush syndrome is a reperfusion injury because of crushing. Okay. Now let's discuss about cast syndrome. Cast syndrome again is a very interesting situation. So let me tell you a story. So there is a patient with a spine fracture. Nowadays we treat it with surgery and other braces. Earlier we used to treat it with something called as a total body brace or a plaster. We put a plaster like this throughout the body, and this can be used for other conditions as well. So basically, when you put a plaster like this and you send the patient home, sometimes what happens is that the patient comes back after 24 hours with severe vomiting and abdominal pain. And this is what we call as cast syndrome. Why abdominal pain and vomiting? What is it to do with the cast? See, what happens here is that because there is a cast around the body, maybe the cast was too tight. So what will happen? It will compress the abdomen. And when the abdomen gets compressed, it will compress the superior mesenteric artery. And remember, superior mesenteric artery is a branch of the aorta, and the anatomy is something like this. You have the aorta here, and you have the superior mesenteric artery arising like this, and you have the third part of duodenum going between the superior mesenteric artery and your aorta, isn't it? So this is the lateral view. You can clearly see the aorta here. So you have the aorta here, and this is the superior mesenteric artery, and you have the duodenum here. What happens when there is a compression from the outside? There will be compression here, and you can see the duodenum is collapsed, duodenum is compressed. Isn't it? You can see the duodenum which is compressed, and because of which what will happen, you get features similar to a gastric outlet obstruction, isn't it? The food that you are eating is not going down into the intestine, it's obstructed there, and the patient will come to you with severe vomiting. So this condition is also called as the superior mesenteric artery syndrome. And as I told you, it occurs due to tight cars around the abdomen, which causes the duodenum to get compressed between the superior mesenteric artery and the aorta, leading to duodenal obstruction. These patients clinically present with severe vomiting. How do you treat it? Treatment is by cutting the plaster. So that's it.